Welcome to everybody on the call. I'm Mike Van Meter. I'm the program director here at McGovern Med at UT Health. Some of you might actually still know us by our old name, UT Houston. It's dying a long and slow, painful death. But we are so happy to get to see some new faces and hopefully show you ours. And I'm going to keep my comments pretty brief because I think the idea here is to share with you tonight 6 different facets of our program, 6 different sections. And it's going to be just scratching the surface. There's a depth and breadth that we just don't have time for, but that's the goal of the Q&A at the end of all of this, is you'll be able to ask questions as things come up. And hopefully this sort of piques your interest. If you have a question, what we'd like you to do as maybe the numbers grow, I think right now manageable, but as we get a little bit bigger in the call, the idea is just type it into the chat and it can be directed towards an individual and just put who that is versus a general question. And we have a couple of our chiefs on the call. Once we're done with our sort of brief introductory presentations, we'll have the chiefs kind of MC the rest of the Q&A, and they'll bring those questions back to the group. We'll answer as many as we possibly can tonight. So thank you for joining us. And with that said, we'll go ahead and get started with the first aspect of our program we wanted to sort of highlight tonight, which is diversity and inclusion. So I'm going to let Dr. Kosoko introduce herself and take it away.
Hi, everyone. I'm glad to see you guys in this format, if not in real life someday soon. So I am Dr. Adiola Kosoko. I am an emergency physician, pediatric emergency physician. I'm one of the assistant program directors, and I'm also one of the director of diversity, inclusion, and mission for our Department of Emergency Medicine. So first things first, I would say for those of you guys who don't know much about Houston, Houston is the most diverse city, according to studies in the year 2019. We don't count 2020 for much of anything, but in 2019, the city of Houston was ranked #1 for ethnicity, socioeconomics, cultural representation, economics, household variations in household, religion, and sexual preferences. And it has been said by our mayor, Sylvester Turner, that one of the biggest goals moving forward with our city of Houston is to increase our inclusivity. I know that we weren't really supposed to have graphs, but I think this is important because for our program, you can see here, we have 60 residents total, 20 per year. We are currently at a 50-50 male to female ratio. And I was like, am I playing with the numbers? I'm not. There it is. When it comes to racial or ethnicity breakdown, what we have here is 52% of our program would identify with majority race or white. But here you have on this side are people who would identify as minorities in some fashion. So the 20% would be people who identify as minorities according to actually, I should say this whole 20 and 28%. So that's 48% of our residents would identify as minorities according to US representation. But the 28% is interesting because that is the representation of those who would identify as underrepresented minorities by the ACGME's definition, including African Americans, Native Americans, and Latinx Americans. And important to also remember with diversity, we have a diverse representation of states represented in our program. It's something that we're really proud of. Certainly, we are a University of Texas school, and you can see the majority and the deepest hue is going to be from Texas. But we are glad to say that we are having many states around the country being represented. So that said, We have, in addition to those, we have great representation of various sexual orientations, race, prior life experiences, including work experiences and military experiences. From my latest count, I don't know, the residents could surprise me. We have 5 children represented amongst our residents' offspring, and we have international graduates and DOs. At the departmental level, we have liaisons to SNMA and LMSA, which are run through the medical school. We have sponsored and have relations with FemInM, which is a large organization for the advancement of women in emergency medicine. And last year, we were actually able to send 4 residents to the conference to come back and share some of their insight with us. We are developing a diversity roundtable in a women's group, and we have adjusted our curriculum to be integrated regarding issues of diversity, inclusion, and health equity. Our School of Medicine is very active in terms of offerings for diversity and inclusion, and takes the matter very seriously. Most recently, they've implemented a virtual speaker series, and unfortunately it's virtual simply because COVID. But also for any resident who would be interested in joining or learning more about Houston and our ranks, it's important that I would also mention that we are the healthcare providers to one of the most vulnerable populations in the city of Houston, which is our community over by LBJ Hospital, which is essentially a healthcare island amidst the huge country of Houston. So I really hate to have to squeeze all of that into that little bit amount of time, but certainly I'd be totally open to any questions. And I actually have Dr. Osa, one of our chiefs, here to just give a couple of cents regarding why his standpoint on diversity and inclusion for our program.
Yeah, thank you, Dr. Kosoko. So yeah, my name is Abiola Oso. I'm one of the chief residents here at McGovern. And so, for me, I remember being a 4th-year med student, and just one of the things I really cared about was diversity. Like, I remember going on all the program websites, looking at how all the residents look, and like, okay, he looks like me, he looks like me, she looks like me, and that's kind of because you want to be in a program where you feel comfortable. And again, I'm from Atlanta, Georgia, pretty much born and raised. It's a pretty diverse city. And so for me, diversity was very important, not only within my colleagues, but also the patients that I treat. I want to be able to treat a wide variety of people, not just race, but, religion. There's so many nuances in treating different people. And for me, I want to be able to help bridge that gap. Part of my background, I was a patient sitter when I was an undergrad. So I sat with psych patients. I sat with patients who were fall risk. So many times, being a sitter, no one really notices you in the room. And so you're just kind of a fly on the wall, essentially. And you see so many, stereotypes being reinforced and patients not really being, heard, and a lot of times so many things are just going above their head. And so part of the reason I want to go into medicine in the first place is to bridge that gap and help advocate for patients, whether it's language barriers. And we have a large Hispanic population. And so, part of our job is helping to allow them to understand what's going on with their care. So many patients, will have diseases and they don't even know they have it. And so anyways, that just goes on to say that, a part of why I came here is because I wanted to treat a diverse population. We have a very diverse group. We have, like Dr. Kosoko said, people who are married, have children, people who are single, numerous members of the LGBT community. We have a ton of African Americans. We have Hispanics, and it matches the population that we see here in Houston. So that was a huge reason why I came here. I have been very involved in the diversity and inclusion efforts that we've had here. We recently started a cultural competency series that kind of started the George Floyd event. And now we're addressing issues that comes up, such as microaggressions, implicit bias. I remember last year we had a senior grand rounds in which we got to, take an implicit bias test and kind of realize, what things may be happening in our subconscious. And so those were things that makes me love this program so much. In our program, we have 11 women. In my class, I should say, we have 11 women and 9 men, which is incredible. Same thing with our intern class. There are also 11 women and 9 men. We have 6 African Americans in my class alone, which is incredible. And so a lot of programs, talk about diversity and inclusion, but, the proof is in the pudding here. Even our faculty we have numerous faculty members from all over the country, from New York, from the West Coast, from the South, from other countries, and it all adds different perspectives. We're learning from each other, and it's incredible. So that's my spiel. Thanks, Dr. K.
Awesome. Thank you, guys. Let me unmute myself. So just for time's sake, we're going to keep on moving right through each of these facets. But like Hutch, one of our other chiefs, was in the chat there. We've got a few questions starting. Please put questions into the chat so we can start that process. And if we don't have any there, you can of course shout them out at the end. But our next group is going to be kicked off with Dr. Rogg, who's going to talk about our administrative group, which is actually a growing group as well. So we have Dr. Rogg and Dr. Hopkins, I think, will join him in a second. So Dr. Rogg, take it away.
Thank you so much. Yeah, it's really great to meet all of you guys. And if you have any questions, feel free to reach out to me or any of the other faculty or residents as you go along through the interview process. I want to talk to you a little bit about admin. So my official title is Vice Chair for Strategy and Operations, and I don't really know what that means. But what I do know is that administration is something that a lot of people don't think about in emergency medicine. And really the goal of what I do is try to support physicians and provide high quality care with the resources that we're given. I try to make everyone's job easier. And we're very lucky here that we actually have a really strong administrative group. So we actually have 2 faculty who are fellowship trained in emergency department administration, which is a growing field in EM. We have both medical directors of our 2 facilities. We have IT, QA, we have our internal budget officers, and coding and billing is all done in-house in our department. Additionally, very exciting, and this is the first time I get to announce it, but we're actually starting an admin fellowship for next year. So when you guys come to McGovern, we'll have an admin fellow who will be someone who finished residency, who's getting additional training and an MBA that will be working with us. So I'm very excited for that as well. Just to give you a little background on what our department does, you guys probably have looked at least a little bit about what we do for our EM residents. And we work in 2 very large academic centers in Houston, the busiest trauma center and the busiest hospital in Houston. But what a lot of people don't realize is that we also run 3 pediatric emergency departments and a very large hospitals group. So our department is in charge of both academic and community practices as well. I want to put a little bit of context around what I do in admin. So as you guys know, Hurricane Harvey hit Houston a couple of years ago, and one of our major projects was to redesign the flow of our patients at one of our hospitals at LBJ. The work that we did there has been featured in peer-reviewed journals and has been featured also in the Harvard Business Review. So that's something, if you guys are interested in learning more about kind of what we did and what admin really does, I think that's a great example. I'm happy to provide you the links or the references to those articles. Another thing that I do that I actually get great pleasure out of is I get to fight with the insurance companies to ensure that our docs get paid for the work that they're performed. And this is something I feel very passionate about, that you guys train hard, work hard to become good doctors, and you should get paid fairly for what you do. So that's just another part of what I do. Now I want to shift gears a little bit and talk about what opportunities there are for you guys as potential residents. So we offer an admin elective, which you can take in your 2nd or 3rd year, and we offer a bunch of research projects related to admin that some of our residents choose to do. And I'm going to introduce Dr. Hopkins, who's one of our senior residents who did her admin rotation in March. I'm going to let her introduce herself a little bit more, and then I want to ask her a question about her rotation.
Right. I'm Jasmine Hopkins. I'm a PGY3. I went to Howard University in DC with now more of an interest in academics as kind of my niche within emergency medicine that I chose to make my career longevity through.
Great. So, Jasmine, you were actually on your admin rotation at a really interesting time. You were on your admin rotation in March as all the planning for COVID was going on. What did you find kind of most interesting, or what can you say that you learned about attending all the COVID planning meetings?
Well, during the admin month, you can work at both Herman, like the large academic, as well as like LBJ, Harris Health System, the county. You learn very quickly that they operate very differently, and kind of can work your way through how you would see yourself in admin. Oftentimes in those meetings, we were with the CEO of Harris Health, personnel, patient policies, testing policies in terms of what we have for COVID testing and finding capacity in an already stretched hospital system. You realize conversations are very different between the two hospitals, and it can give you a better outlook on all the different aspects of admin. I chose more of like a county route in terms of what I would choose to do in the future, but we were very valued there. I came up with a lot of the patient policies, testing policies, as well as the kind of working of personnel within the department, not just doctors, but as well as EVS and nursing and other patients, people within the hospital that you don't think about, like the tech, the things that you have to consider during this time. That was very good to kind of get more of an interdisciplinary approach during this time. It definitely was more geared towards COVID because that was right at the beginning of when COVID in Texas took off. But it very quickly, you kind of can get down the rabbit hole of where you see the most interest and what you think you can be the most helpful in your future career. A very balanced outlook from the program versus other places because of that 50-50 mix of county and academics that we do.
Thanks, Jasmine. I'll turn it back over to Dr. Van Meter, but if you have any questions, feel free to reach out to me.
Awesome. Thank you both. And we'll just move right into pediatric emergency medicine. We mentioned three peds emergency departments underneath our purview. So Dr. Gowrie Stevens, who's also one of our assistant program directors, will take it from here.
Hey guys, so welcome. We're so excited to have you. I'm going to be talking, so I'm Gowrie Stevens, one of the pediatric emergency medicine docs. I'm going to be talking about our kind of your children's hospital experience. I was actually going to have Michael Vu, one of our second year residents, started off. He had some really good insights into the pediatric experience, and I wanted him to start it off. Michael?
Yeah, for sure. Everybody can hear me okay?
Oh,
okay,
I'm
perfect.
good, thank you. Sorry.
So
yeah.
I'm Michael Vu. I'm one of the second year residents. And I wanted to talk to you all about our pediatric emergency medicine experience here.
I'm on the WebEx meeting, but
I think one of the
mute, so
big things that is a benefit and a unique portion of our program is that we have a very robust ultrasound division to start with, but we actually have pediatric emergency medicine, pediatric emergency ultrasound fellowship trained faculty working with us in the department. So I think given, the volume and the acuity that comes into our PEDS-ER, it's very useful and very educational to have those faculty readily available to help with scans and give us that extra bit of exposure that you might not otherwise get. And I think that another great aspect of our training here is just the way that the PEDS rotations are structured. So at some places you might rotate in a pediatric emergency department for like a month, once during each year. But for us, we do get a full month of exposure during our intern year. And then after that, it's more of a longitudinal experience where you have those PEDS shifts sprinkled in throughout the rest of your residency. So it's almost like spaced repetition in a way, and it helps keep you fresh, keep you thinking about, the PEDS aspects of emergency medicine, and then ultimately helps you become a lot more comfortable taking care of children and sick kids once you get out of residency.
Yeah, I love that. So I think so. Like Michael said, one of the big things is that longitudinal shift. So every time you're on an emergency medicine month, when you're with us, you're doing a couple pediatric shifts. I'd also like to add that you get a month at Texas Children's Hospital down the street as a second year. That's another kind of extra pediatric experience that you get. Just a kind of overall overview of the way it works is our children's hospital is within the adult hospital. We're a 13 bed little ED, and we have a really good mix. So one of the things I love to tell applicants about our PEDS experience within our ER is that it's just an amazing mix of kind of lower acuity coughs and colds all the way up to kind of chronic, really complex patients. And sometimes when you work at a children's hospital or you rotate at a children's hospital, you kind of get narrowly focused into just the kind of more chronic patients, more really complex patients that are really difficult. And those, we definitely have that. But, we likely also have kind of the cough and colds and the kind of more general PEDS things as well. So we have normal kids who get sick and we have complex kids who get sick, which is a really good, really well balanced. I think it's kind of a really ER to teach emergency medicine residents pediatrics. Another thing that we really focus on is kind of graded autonomy. I think that's something that is something very unique to us. So obviously as an intern, you don't want us to just let you run free. You don't want that. You want us to kind of help you, guide you through pediatrics and kind of help you along. And we certainly do that, especially with that first month. That first month, we really try and get you acquainted with pediatrics, get you to know all the different attendings that we have. And so you really kind of, we kind of gently push you in. And then after that, we kind of slowly get to know you. And over time, you do get a little more autonomy. So as second and third years, we try and we trust you a little bit more. And I think that's a unique experience because, in pediatrics, as many of you may have seen, we really, we try to be very careful about sticks and pokes and things like that with our pediatric patients. So to be able to get trust from your attendings, to get autonomy and manage patients on your own, that's really important. And also it's difficult for us to do. And I think most of you, if you've potentially rotated through the Children's Hospital, have seen that. Another thing I'd like to highlight is our pediatric simulation. So I'm also the director of simulation for our department. So, we have kind of an amazing kind of pediatric longitudinal simulation curriculum. So within the 3 years, you'll get various kind of more rare pediatric experiences through simulation. So, it's not always these intubating patients is not something that we do that often anymore in pediatrics because we have vapotherm and high flow. We have CPAP. We have other ways to kind of, keep kids from having to get intubated. So it doesn't always happen. So it's really important that you have those experiences and to get comfortable. And I feel like simulation is a really amazing way to kind of get that experience. There are other kind of rare presentations that occur. For instance, today we did a methemoglobinemia case. And it's a hypoxic baby, but it's not the heart and it's not the lungs, right? So it took everyone a little bit of time to get there, but all my teams got there. And so, we try to throw you into some rare cases to try and mix things up. Last but not least, we do have PEM fellows in our ER. And sometimes people think, oh no, they have PEM fellows. That's going to detract from my learning as an EM resident. I ask the residents how they feel about that, but I do not believe that's the case. So our PEM fellows especially our upper level PEM fellows, are there to teach. And so they guide you through your procedures. It's almost like having an extra attending on shift. So when we have, a lac repair and we have an intern who has a lac repair, the PEM fellow, if they're on with you, can guide you through it and help you with sedation, making sure the kid is sedated appropriately, making sure the procedure is done correctly. I think it absolutely adds to your experience, doesn't detract from your experience. And that's pretty much it. I'm happy to answer any other questions that you guys have.
Awesome. Thank you both. So we'll move into critical care now. And I think we have Dr. Doshi and Dr. O'Connell on the line for that. So I'll pass the mic to them.
Hello all. I'm going to turn on my video just for this minute here because I'm still at work. So welcome. It's great having you guys on this conference call. So as everyone has mentioned, one of the greatest strengths that our program offers is the pathology that our trainees get to see. And this is between both our county site and our tertiary care site. And this holds true for critical care as well. So over the years, we have really focused. We're very fortunate to have 4 critical care trained faculty as a part of our Department of Emergency Medicine. Dr. Hudson, who's a surgical critical care trained, Dr. Demla and Dr. Tupchung, who are medical critical care trained, and I'm medically critical care trained as well. And I've been here for about 12 years, and over the past 12 years, we have done a variety of things that go along with increasing our critical care education and improving our experience. So our residents get to rotate through every ICU in our tertiary care site, which includes neuro ICU, surgical ICU, or trauma ICU, medical ICU. And over the last 2 years, we've actually created an elective for rotation in the mechanical circulatory support ICU that we have. So taking care of ECMO and LVADs and all those populations. And we've had about 2 or 3 residents take advantage of that elective. We have again, at the end of the day, our goal is critical care starts with us in the emergency department. And we want to make sure that we understand what goes on upstairs so that we can make sure we start that process early downstairs. And that's really been the focus of the education. And the main core of the education is we have vice chiefs of critical care in our department. And we have every other month, we have a critical care case conference, just like Dr. Stevens was talking about the SIM cases. We take about 2 cases and we take a really deep dive in each of those cases that allow us to go through a case in a controlled setting so that when we actually see the patient, we know what to do with those patients to begin with. We've had 2 people go into critical care fellowship over the last 3 years in our program. And I would like to pass it off to Dr. O'Connell, who's also hoping to do the same.
Yeah, so hey, I'm Dr. O'Connell. I'm Danielle. I am going into the surgical critical care fellowship that Dr. Hudson, one of our other faculty, went into. Going into residency, I knew that I wanted to do critical care. So I was really thankful. And, whenever I was looking at residency programs, I would look at the critical care experience that the residents would get. So I was very thankful that we got all of this critical care experience during residency. So we'll do at least 1 ICU per year. And then on any given shift, we'll have several critical care patients, like many ICU level patients. So we are just exposed to critical care all the time. This is something that, whenever I was looking at all the different residency programs, I would look at the acuity of care for any given shift. And this, really stuck out to me. So I'm really thankful that we have this opportunity to see all the different, possibilities within critical care. I didn't know what kind I wanted to do until I rotated through all of them and found that I really liked the surgical one. I did speak with one of our co-residents. She's a 2nd-year resident, Tony Miller. She went through the HVI ICU, which is mostly ECMO patients. This is something that you don't get to see everywhere. ECMO is amazing, and it's actually pretty rare. And so it's cool that we have an ICU that has so many ECMO patients. So it's a cool opportunity. I think we have, just the acuity of the patients that we see at McGovern at both Herman and LBJ is just, unmatched.
Yes, and I think what has happened as having cross-trained faculty that work in both departments, we've actually really have a wonderful relationship with our critical care group. And we've been able to do things, as one of the comments just mentioned, we actually cannulate for ECMO in our emergency department. And that's not an uncommon phenomenon. That happens, at least a few times a year that we're taking patients and cannulating them in ECMO. And I think with COVID, that has become even more prevalent for some of these hypoxic respiratory failure. And it allows us to really take care of our patients as aggressively as we can. And the second part of this is we actually are training our trainees in a different way than most places. So I happen to work at a community site as well. And in most community emergency departments, when a critically ill patient is identified, the goal is to get that patient up to the ICU. Unfortunately, we don't have that luxury at our campuses. And as a result, we get to take care of these patients for a prolonged period of time. And simple example, diabetic ketoacidosis generally is an ICU admission. But if you look at our numbers, we only admit about 25% of our DKA patients to an ICU. We fix the DKA and then we admit them to the floor. And that's just an example of bringing the ICU down to the emergency department, taking care of these patients well. So thanks for having us. It's great to see you guys on this call, and we'll be waiting for a call for any questions that you have.
Wonderful. Thank you both so much. And so next up, we have communication. So I'm going to let Dr. Fadial take over, and I believe we have Dr. Calderon on as well.
Hey, everyone. My name is Tom Fadial. I'm the Educational Technology and Innovation Officer for the department, which I translate to being the department nerd. And what that means is that I help the residents kind of create what they want in terms of education and tech. And so just to go over a few of the examples, we run our own internal education website that is operated by the residents. They use it to aggregate and share educational information among one another, including visual diagnosis cases and other sort of interesting ECGs that they come across. On the operations side, we started a wiki for our department, and lots of involvement from the admin and operations teams goes into that. Dr. Calderon is going to talk a little bit more about the social media and communications side of things, but with Dr. Salil Bhandari, who couldn't be on this call, we've been able to develop a pretty visible outreach program to our community, both targeting Spanish-speaking patients as well as kind of the broader public, trying to educate about things like COVID and mask wearing, and then before all of this, all the other important medical topics that people don't know enough about. And other projects that we've worked on it's basically my role is to realize something interesting that you want to make. So a couple years ago, I worked with Dr. Reynolds, who's now the clerkship director on ECG Stampede. And we basically created this website, and it's turned into a legitimate ECG curriculum now. And I'm working on a similar project with our education fellow this year. So if you think of something interesting, I'll figure out how to make it work. We just need, a good idea and some dedication. And I think there's the main point is that from this side, we get to interact with all of the different sections in the department. Anything that involves education, pediatric emergency medicine, ultrasound, admin, even extending to medical school and undergraduate medical education, we can get involved in kind of through this communications platform. And honestly, the things that Dr. Calderon has done are some of the most exciting. So I would much rather she talk more.
Hi, everyone. It's nice to see you all. So like Dr. Fadial was saying, there's so much growth and opportunity. You can make it whatever you want to make it. He's amazing, and he is just great at anything technology, which I am not. And I was intimidated at first, but honestly, it's been a great adventure. From the communications aspect of it, I've been on Univision speaking to on the Spanish news with the outreach, like he had mentioned. I know a lot of our faculty have been on, like Dr. Fairbrother, Dr. Bhandari, they've been on major news channels as well, talking about COVID and other health-related issues, because I know right now that's kind of the best way to outreach our community. From social media aspect, we are starting the chief introductions. So definitely follow us on social media for more information. And we're going to be starting a day in the life of the residents, so you guys can kind of get an idea here in the next few months before interview season starts of what it's like to be a resident here. We also are making an exciting video that will be out soon, is a kind of a promotional video for our residency, so be on the lookout for that as well. And like I said, you can make this whatever you want, and that's all. If you have any questions, let us know. It's been really an honor to work with everyone here. Everyone's so amazing.
Awesome. Thank you both so much. I think Camilla alluded to the fact that Dr. Fadial Tom is underselling his abilities to make, an idea come alive. And I think we've seen that a number of times, and you'll start to see more and more of that pushed out into the world, which is awesome. Okay, so I was waiting for Dr. Chambers, who was on shift, and so she, I think, is on our call now, and she's going to talk to you a little bit about the research interface between faculty, residents, and just our overall growth in research over the last couple of years.
Hey, everybody, welcome. It is great to see you. Sorry, I'm looking crazy. I was under a mask and all that stuff at LBJ just about a half an hour ago. So I wanted to start off with a quote that I love that sort of encapsulates sort of my thinking about research and why we do research. There's a quote by Voltaire that said, "Doctors put drugs of which they know little into bodies of which they know less for diseases of which they know nothing at all." And so I hope since that time that Voltaire said this, that we've made a little bit of progress. But one of the things that happened when I was doing my research training early on was I heard about these cases where somebody would have an idea of what they would think was happening on a physiological level and what therapy should work. And then we would go and test it and find that that is really not how the body worked at all. And that we were sometimes making things worse by what we were doing. And so to do research is very humbling. But when you hear about evidence-based medicine, you really realize that you are standing on the shoulders of everybody that came before you. And so research is incredibly important, and we're the only ones that can do it. And by we, I mean academic medicine. This may be the only time in your career that you get a chance to do research, but you'll be reading other people's research for the rest of your career in journals. So it is important to have some experience with research and with journal articles while you're here. We happen to have one of the most prolific emergency medicine physician scientists in the country, Dr. Wang, who is our research director. He's known nationally, internationally, and has helped residents do presentations on a national level. People who have had ideas about things have gone and presented at cardiology conferences. His work was in JAMA on EMS. We also have multiple data sets and databases that we keep with trauma, with cardiology, with stroke. And so you have a lot of opportunities. Sometimes research can seem very daunting because there are so many moving parts, and to do a research study there's a second set of skills that you need. But our group has just grown incredibly over the past few years. So we've seen so many residents work with so many different faculty. If you don't want to work on big clinical trials, you don't need to work on big clinical trials. We have seen Dr. Cooper from the education department does a lot of publications of interesting EKGs that everybody can learn from and that people in the discipline can learn from. Dr. Fadial has done communications guidelines that people can use. We've had people do clinical images with one of our faculty who's not doing clinical work anymore. So you can do case reports, you can do that are small, you can do things that are large. You'll look at the publication list and you'll see tremendous diversity. Book chapters. One of our faculty put together a book on the myths of emergency medicine and debunking some of them, things that people do in practice all the time because they've heard that's the right thing to do. He takes a look at the evidence. So I can't get into everything that everybody's doing. We've had recent sepsis trials that one of our faculty was on a new JAMA article. So we've had tremendous success over the past few years with people presenting on a national level. And you can get involved with any of those kinds of things, just reaching out to faculty and asking the other residents who they've worked with. But just so you understand, there's a continuum and that we're here to help you, and we want residents involved in all of our projects. So just reach out. We keep a data set of or a little spreadsheet that has opportunities, but there are also more opportunities that aren't listed there. So just ask around, whatever your area of interest is, whether you want a big project or a small one, we should have something to accommodate you. So welcome again, and thank you for letting us present.
Awesome. Thank you, Dr. Chambers. So that was the slightly longer than we anticipated overview of our program, which is always, I think, the case when I'm involved. So thanks to everyone for presenting. I think that was a really nice slice through 6 different facets of what we have to offer here. And we if you look at the agenda for next Thursday, and there's something on there, we're going to talk a little bit about it then. But you're welcome to ask anything and everything. We have some time here at the end for Q&A. I think actually a lot of the questions might have been answered during the course of the conversation. But anybody on the call, feel free to chime in. Everybody who's not talking, if you don't mind muting your microphone after you ask a question, we can just go from there. And or if there's something that the chiefs remember that we didn't quite answer or we needed to clarify, you can throw it back to anybody. Dr. Fairbrother, did I see you raise your hand earlier?
I did not, but I'm happy to say hello, everyone. Hillary Fairbrother, I'm the Vice Chair of Education, and it's my honor to serve that role for this amazing department. I am firmly mid-career, as I like to call it, rather than just being old. And I've had the privilege of working in multiple emergency medicine residencies throughout my career, and I have definitely found my home in this one. This is a special place, and I'm really excited that all of you are here tonight so that we get to share a little bit of our experience and our family with all of you.
I don't know if this was addressed in the chat or I saw it way early on. I think there was a question about community outreach. That's going to be, we do have somebody speaking to that next Thursday night. And actually, we're recording this and we're going to record next Thursday as well. So you can always check back with our departmental website. We'll post it there just in case, you know, somebody needs to come back, look at something. Or if you have a friend who couldn't make a call, feel free to refer them back.
Dr. Beamer, someone asked in the chat to speak about how our didactics are being run during COVID.
Yeah, and so Dr. Cooper is our associate program director. He's not on; he's working clinically right now, and he's actually going to give a little bit of a talk, an overview of education within our program next Thursday. So there might be a little bit more information there. But briefly, we did have a little bit of a lag, but I think really, I mean, I'm also privileged to be surrounded by the people on this call. It's an amazing, amazing group that I think rallied quickly, and we've got both in-person and largely virtual education that's taking place. So we'll have lectures, we still have grand rounds, speakers visiting virtually, and we still have in-person sim, although we've thinned that out a little bit, and some of it's sort of where do you feel comfortable? Do you want to do this via WebEx or do you want to be in person? We have in-person small groups as well, with social distancing, physical distancing, masks, all the good stuff. But yeah, no, I think ultimately, I feel like we're, you know, we like to be in person as much as possible. That said, I feel like we're back to a place that is every bit as potent from an off-shift education perspective as we were pre-COVID. We've really kind of rallied around a lot of our resources, reinvented a number of things, and it's going pretty well. That's my maybe rose-tinted view of it. And residents, please chime in and tell me otherwise. We've got, I'm sure, like Hutch, you're on the call. Oh, so you're on the call. Sure. These are two of our chiefs that help run conference, so we'll put them on the hot seat.
Okay.
Little choppy, but we got you.
Okay. I think it was of a how to go the educational. Why don't one of the other step in for just a second? Let me square away my audio. I apologize.
Yeah, I'll go ahead and step in. I think I just having some technical difficulties. But no, so our conference has been pretty interesting this year, but we have made it an incredible situation. So obviously, everything's virtual these days. So we have incorporated a lot of different things, such as Kahoot and different games to make conference an enjoyable and interactive experience. Although it's still virtual, and for our oral boards in sim, we still come to campus, and we social distance, we maintain the rules, but we still are able to do conference at a high level. We're still it's actually made it easier because now we're able to invite a lot of guest speakers from different parts of the world, different parts of the country, to give us talks and things like that. But what was the direct question? I think I missed that part.
It's just like, what's our style? Do we do like a reverse classroom teaching? Just kind of how our didactics run, like flipped classroom, small groups, lectures. And I guess I just elaborate. We do all of it. Literally,
it's a great mix.
We have like some intern run case series, which are excellent. They can pick a case that they're very interested in, and they can present it along with a faculty advisor, work through the case with everyone. Like during conference, we also have like quality assurance where we present all the previous cases, which is probably one of the best learning opportunities, at least for my style of learning. Some people really like lectures, and I do learn from lectures, but working through a case where another person who's as skilled as myself, if not better, got it wrong, or maybe could have done something a little bit better, you learn a lot. We have a really robust quality assurance program here, and it will make you an outstanding physician by the time you graduate.
Yeah, and I'd add on to that. Next week, we have quality assurance up on the docket as far as discussing that part of our program. But the lectures, one of the things that I think has been one of Dr. Cooper's big things was to shorten our lecture length to about our average lecture length to no more than 30 minutes. So that things are dynamic, things don't just sort of sit there and get a little stale during conference. So we mix it up. We keep it interesting. I think our conferences are overall incredibly well run, and there's a lot of work that goes on behind the scenes to make that happen. One of the other offerings there that I think is really awesome is our senior grand rounds. Our PGY3s will give a 30-minute grand round style talk on a topic of their choosing. And from start to finish, from the topic choice, outline of that topic, building the talk, building your slide set, refining that presentation to a national caliber. And really all of these are given at that level. That is coached by one of our other assistant program directors, Dr. Bhandari. I don't know if you're on the call, but he's done just a fantastic job with that. And I think I don't know if we have any of our PGY3s have already gone through that with him, or are currently going through that with him? Nope, not yet. It's really awesome. And he's really revolutionized that particular piece of it. He's also, I think, working with our interns on some of these case presentations. So I'll sing Dr. Bhandari's praises for that.
We've got some great questions in the chat that I want to pivot us to. Because we aren't having you interview, of course, per COVID, what is our pod and kind of organization on shift is one question. How are traumas run is another question. And what is the faculty to resident ratio is another question.
I can answer all of that, but do you have any residents that want to chime in?
I can. I'll at least talk about the faculty resident ratio. It's kind of built into how we have pod. So at Herman, there's like a PD pod, which usually is 2 residents with an attending. That'll be a mixture of EM and PD residents, usually 1 and 1. Sometimes it's 2 with the attending, and then there may or may not be a fellow during that given shift. Trauma, it'll be 2 to 1. Usually it's a senior and an intern. Occasionally it's 2 seniors. Medicine is the same setup. The trauma pod is just as busy as the medicine pod, I should point out. You'll do about half your shifts at Herman. You're like, you can't possibly be kept busy with just trauma. And I tell you, you definitely can. You'll probably be busier on trauma sometimes. Then at LBJ, the staffing is a little bit different from our traditional staffing because right now we do have a COVID pod, which is usually also 2 residents, senior and an intern, with 1 attending. And then we have a critical care pod, which is usually senior solo coverage for the entire shift, but there is a swing shift that's usually kind of available for interns as well. So you pretty much almost always staff directly with your attending. Your upper level as an intern will always be there to staff with. We're actually starting some practice with the PGY3s. We'll get to staff the off-service patients. So the off-service residents will staff with the 3, and then the 3 will aggregate staff to the attending, just to kind of give you a little more of the academic flavor and just kind of learn how to not see patients primarily and just kind of still put in your advice, because you'll do that in the community with APPs and you'll do that in academics as well.
And actually, the question about how do we work with trauma, I think we have a really wonderful relationship with trauma. Airways are managed by emergency medicine. Level 1 activations are jointly managed between trauma and emergency medicine, and everything else is managed by emergency medicine. So we get the consultant involved when we feel the need to. We have a very high, we mentioned this a few times, and actually that might be one of the idiosyncrasies of our shop. It's not often that you have a full side for trauma and a full side for quote unquote medicine patients. And so like that surgery versus medicine is like a 40 or 50, 60-year-old idea. And it doesn't really exist anymore because you're an emergency physician. You take care of everything. But in our shop, we do have to separate those out because of the just glut of trauma that we have at our shop. It would grind the place to a halt if it wasn't managed as its own entity. But I think it's a really great relationship, and our level 2s are super, super sick. The vast majority of them as well. And so I think we have a really great experience, a really great collegial relationship with our trauma surgeon, and something that there's enough to go around. Everyone recognizes that. So I don't know if that answers that question, or if anyone else wants to chime in on that.
Are you guys able to hear me now?
Much better.
Okay, my apologies, team. I believe you're just asking for people to chime in on the relationship with trauma. Is that right? Okay, I would love to. I know that as a third year, one of the chiefs, I've had the opportunity to go through STICU, which is where you form pretty much your real initial relationship with the trauma service. And then also, as a second year, I did the trauma surgery rotation, which is a 2-week overnight element where you only work on peak trauma days. And again, you get very incorporated with them. Trauma is a big concern for all medical students. I can remember being really concerned about it. We have such a great relationship with our trauma folks. I walked in a shift, and one of the first questions I ask when I'm on trauma is, who's the trauma attending? It's nice to know who you're working with and the opportunities that we've had. This is not everybody, and I feel very fortunate for this. I personally have done 2 ED thoracotomies as a resident in the emergency department, working hand in hand with the trauma attending staff. We're very busy. We see a huge amount of traumas, and if you put yourself in the right place, there really are endless opportunities. I know it's not just me that speaks for a really solid relationship with our trauma faculty and trauma residents.
I'll have to comment for you, Hutch. Thank you.
I saw that, sir. Thank you very much.
Yeah.
They were still performed regardless. Okay.
Just glad we can hear you. Another question, what do you guys like most about your program, and what is the one thing you want to change about the program?
Ooh, that's a great question.
Oh man, it really is. It really is a great question. I think what has surprised me as a third year and a chief is how fast this program has gone, and I think the idea of coming to the end of 3 years and the relationships that we have formed. We have so many cool things here. I mean, we've just talked about trauma, but we also have EMS opportunities that I have a personal interest in, and all kinds of different avenues to explore your passion in EM. But without a doubt, and without even a second thought, my favorite part of this program is the people. I know for a fact that somebody up in the chat box had asked, how do we kind of get by with such a huge volume of residents, and if we feel really separated? But I can tell you that we end up seeing all these faculty on such a regular basis and working with folks on a regular basis. And I just feel that the family here is so strong that that's part of why I redirected my own academic pursuits and am now trying to gain a fellowship here and eventually would like to stay on with this team. So that's easily the best part. In my opinion, the personal thing that one thing we could change, that's always a tough question. I'm also an honest person and I'm a hungry bear. So I would say more free food, which actually is something that we are working on.
Yeah, no, wonderful. I think there are always things that we're working on, and there are always things that I want to change as program director. And so one of the areas that we're trying to tweak is our Picu experience. And so Picu, I think the world over, is a place where you have very sick children with very concerned parents at the bedside 24/7. Which leads to less autonomy. And our PGY3 is, by the time you get to being a PGY3 in our program, you are a fairly autonomous entity. You function well. You make decisions efficiently. And that changes a little bit when you get to Picu. And that's when that particular rotation is. So we're in the process of moving it into a PGY2 rotation. Because that culture up in the Picu is difficult for us to work on. So we're going to move it a little bit earlier. And I think the idea is also we're soliciting feedback constantly about that rotation, but all of our off-service rotations. We're constantly looking at things annually with regard to the block schedule to try to make sure that we're doing the best we can with regard to staffing in a circadian fashion, for example, in a respectful way. We're fixated on those type of issues, but I think there are a lot of moving parts in a program our size, and there are pros and cons to that. And I think, most of the time get it pretty close to right. And the times we don't, we hunker down on that particular thing and we fix it. And that's a grassroots thing. We're a resident-led program, a resident-driven program. So the residents bring that to this team. And we work on that, and we take it from verbatim and fix it. So definitely, there's no perfect program out there. I wouldn't represent us that way, but we definitely have an unhealthy fixation with the areas that we need to improve on.
Yeah, and I just want to echo on that, on what Dr. Van Meter was saying, because even when you're looking at any program, you want to be at a program where they're responsive to the residents. If there's an issue with a rotation, with the curriculum, you want to be able to approach leadership and not only, just have your voice be heard, but something be done about it. And this is a program that, time and time again, whenever there's been an issue with any rotation, whether it's conference time, whether it's, unfair share of nights, we always address it. Me being privy to some of the chief meetings, I see firsthand that, Dr. Van Meter and the other leadership are, addressing the other specialties to make sure that there's equality across the board. And so that's something, you guys need to look for in every program.
I see a great question there about shift breakdown per year. If you interview with us again, by the way, we'll tell you most of this stuff again. So the PGY1s work at about the national average with regard to hours per month. And at Herman, we still have 12-hour shifts on the weekends, but that again is every year we kind of poll the residents and figure out whether or not they want to continue with that. Every other shift in the department is now 8 hours. So we kind of got away from, we had a sort of a smattering of 10-hour shifts, 9-hour shifts, and then the 8. So we went to all 8s except for those Saturday, Sunday days at Herman. And that was a resident-led choice, like I mentioned, to preserve weekend time. The PGY2s then moved to about one shift a month less than the national average, and the PGY3s are the same, about one shift less than the national average per month. And that's been a gradual progression over the last, I think, about 4 years, starting with the former program director. I continued with that. The idea being that we want to create space outside of your clinical rigor. And that is our program. That's one of our MOs, is we have a rigorous, challenging clinical environment for you to work in and train with. The idea is that you have a little bit of space outside of that to develop yourself in that niche capacity. What is it that you want to do outside of take excellent care of patients? And we want to partner with you on that. And we want to give you a little bit of time for that. We also recognize you might need a little bit of time. You do need a little bit of time to decompress from your clinical workload. And before, we were working above the national average. You combine that with again, the high acuity, high volume settings that we work in. And we have to be mindful, I think, about that balance. And so I think we're at a spot where we don't want to lose the heat ever. I think that's really vital to forging you guys into something that we all are aspiring to be. But the idea is that we keep you, supported, challenged, cared for, all in the same bundle. So does that answer the question? I hope so. So yeah, about national average as an intern, one shift under for each of the other PGY years, as far as the actual distribution. Cool. I'm trying to read the comment and ask any other questions at all. I think we're getting just at the end of our time, but we can squeak out a few more answers for you and then invite you back for next Thursday. Certainly don't have to do just one of these. I mean, they're, come on. There's not a better way to spend your Thursday evening. Any other questions in there? I know, I saw. All right. Well, if that's the case, we'll go ahead and wrap up. Thank you guys for taking some of your valuable time and spending it with us. Please come back next Thursday if you see one of those next 6 things that we were going to talk about. Like I said, it takes a little bit of time to get to know you. We really wanted to do this so that we could extend ourselves a little bit beyond just the interview day. That's so vital, and we think that we're a program that if you get to know us, it is an amazing group of people. It is an amazing place, and you put those two things together, and it's the perfect storm, and that's what we think we are. We want to be candid with you. We want to be honest with you about that, about things that we could do better, about things that we're working on. But I'm fortunate to be here, so fortunate, and just wanted to share that with you. So, sorry, Hutch is waving at me.
So sorry, I just wanted to say one quick plug because I think that this often gets missed, but just a quick props to you guys. This is such a challenging time to be a MS3 and MS4 going into this next step. So just real quick, keep up this willingness to come to these weird, awkward virtual meetings and learning this new stuff just as we're learning it too. So, the chiefs all have our contact information online. Everybody on this call from a faculty standpoint has our information online. Reach out to us anytime, but thank you guys for working with us in this new and different time.
Awesome. Okay. Everyone have a good rest of your night. Thank you again, and take care.